Hi everyone, I want to talk about dysmenorrhea. That is a medical term, medical jargon. Many people will know it as painful menses. Painful menses. Okay, let's go. Dysmenorrhea is simply defined as a painful menstruation. It occurs only close to the onset of menses and during menstrual flow. It is not experienced once there is pregnancy and not also experienced when ovulation is suppressed. So it's all associated with ovulation and menstrual flow. Epidemiology. Greater than 50% of all reproductive women worldwide will have experienced primary dysmenorrhea. So it's not a local problem to any community or race or ethnicity. No, it is worldwide. And a lot of people, greater than 50% of all women within the childbearing age group, would have experienced primary dysmenorrhea. It starts once ovulating cycles are established. It decreases with age. That is good to know that at teenage years, you might be suffering a lot, but the older you become, the lesser the trouble. Pathogenesis here is essentially that there is increase in level of prostaglandin E2 and F2 alpha. This will be released from endometrial slowing at the beginning of menses. The uterine contractions is induced by the presence of these prostaglandins. Then the frequent and non-rhythmic contractions will lead to increased pressure. The increased pressure will lead to ischemia, and then there will be anaerobic metabolites that will start accumulating. With that, that will stimulate type C pain neurons, and the woman will feel the pain. Severity of dysmenorrhea could be in 4 different groups. The first group are those who will not have pain at all. They're not going to feel it. Some people, it's because they have high pain threshold. So it's going to take a lot of painful stimulus for them to sense it. So they are very lucky, but in many people, it's just that it's not going to be that painful. So no pain, and it's not going to affect activity of daily living. In that way, you don't need any treatment. The second group are those who have painful menses, but it will be mild and it will not affect any of their daily activities. In that case, we can just give low dose analgesics, or if they are comfortable to go with it, then you might give nothing. The third group are those that their daily activities will be affected. ADL means activities of daily living with moderate pain, and then you give them analgesic. The worst group are those that activities of daily living will be dropped. In other words, they won't be able to do all they're supposed to do for themselves. So it's severe. They can miss school, they can miss work, call in sick, absenteeism, they have severe pain, they have headache, vomiting, diarrhea. In this case, even when you give your analgesics, the effect might not be that significant. The first type of dysmenorrhea that I will talk about during this presentation is primary dysmenorrhea. In primary dysmenorrhea, just from that simple English word primary means it is there without any other cause, no secondary cause anywhere. So there's abdominal pain, it is recurrent, is associated with menses, not associated with any disease. Not associated with any disease. It's just the problem of ovulation and menstrual flow. That is it, primary dysmenorrhea. And that is the commonest one worldwide that many people, but women of childbearing age group, have suffered from. Now, secondary dysmenorrhea. Secondary dysmenorrhea will present with menstrual pain, but unlike primary dysmenorrhea, there will be associated conditions and be associated with diseases like fibroid. When that is the case, the fibroid will be enlarged, irregularly shaped, and will not be tender. It's possible to be associated with endometriosis, hematometrial adenomyosis with bulky, globular, and tender uterus. Could be associated with pelvic inflammatory disease with purulent discharge, very high temperature, and cervical excitation tenderness. So when the individual, the young lady or middle-aged, 20, 30 years old, is coming down with dysmenorrhea for the first time, has never had it before, then we look for the probable cause or causes. We do ultrasound to rule out fibroid, as about history of infertility or pain at the back, pain at the flank in case of endometriosis, and pain while defecating, hematometrial adenomyosis, check the uterus is tender, and of course, a lot of questions as per pelvic inflammatory disease if there's any discharge. And this woman is now having high temperature. The doctor, the gynecologist might do cervical excitation, and if there's tenderness, can be trying to rule out that a PID and the rest that could give cervical excitation tenderness. So we need to rule out the cause or causes when it is secondary. What are the clinical features? The first is there will be low abdominal pain that might start before the menstrual flow, and it will be cyclic because menses are cyclic, and that's why they call menstrual cycle. There will be associated nausea and vomiting. There could be headache, weakness. The pain is waxing and waning, that is colicky. Radiates to lower back, the inner thigh, the labia, and occurs before bleeding. Remains for about 72 hours. Wow, that is serious for all those affected young women worldwide. The clinical features continue as dyspareunia. I'm not going to go into details of that. Abnormal bleeding, impairing quality of life, because when your social life, your work life, and your own comfort is affected, the quality of life is affected. Activities of daily living will be affected, as I've said earlier, like in grade 4, school absenteeism, calling sick for work, decreased social activities. This is not the time they'll be interested in camping and all other social events. Pain is recurrent. Starts 1 to 2 days before menses, it will be crampy, lower abdominal pain, and suprapubic. It is clinically diagnosed most of the time with history, obstetric history, gynecological history, relationships, past medical history, family history of dysmenorrhea, past treatments, and physical examination. Like when it comes to obstetric history, I want to know when or how many times have you ever been pregnant and the outcome of those pregnancies or that very one, if it's only once. Gynecological history will go into when you start menstruating for the first time, how had been the flow, how frequently do you menstruate, want to estimate the quantity of blood loss during the time, and of course, dysmenorrhea during that time. Relationship will go into what kind of relationship do you have. If you are, I don't want to go into details of that to understand what I'm talking about. Past medical history, if you have had surgery in the past, and where and for what, and dysmenorrhea treatment in the past, a family history of dysmenorrhea, and of course, the doctor might examine you from head to toe. So after taking necessary history and physical examination, ultrasound may be ordered. Laparoscopy or hysteroscopy might be ordered as the case may be based on the suspicion, because particularly with the secondary dysmenorrhea, the doctor will want to go down and get to the bottom of the cause. Without treating the cause in secondary dysmenorrhea, we have not yet reached the point of resolution. So if the doctor wants the woman to get out of the trouble indeed, and this is secondary dysmenorrhea, he or she will do some of these investigations to get to the root cause. If he or she is suspecting pelvic inflammatory disease, he can take swab for microscopy, culture, and sensitivity. And if urinary tract infection is implicated, urinary microscopy, culture, and sensitivity will be done. The treatment, like I've just put it here on this screen, is all centered around this. And that's what? Non-steroidal anti-inflammatory drugs, oral contraceptive pill, and treat underlying cause in secondary dysmenorrhea. Again, I repeat, like you've seen on this screen, everything we're going to talk about as per the treatment is centered around this. Non-steroidal anti-inflammatory drugs, it is better to start few days to the bleeding, then oral contraceptive, combined oral contraceptives mostly, that's what many people will use. Mini pill containing only progesterone could be used as well. But in secondary dysmenorrhea, it is important to know the cause. Do all investigations to know what is responsible, the underlying disease, and treat that. If not, the woman will not get out of the trouble. Okay, now how do we treat these people generally? Heat, by putting hot water in hot water bottle. There is a particular one made for menstrual pain. Get to store, buy that, and fill with hot water. Place that on the painful parts of your lower abdomen. Make sure you are not going to get scalded with that. You can put a cloth between the water bottle and your skin. Exercise improves the situation. So engage in activities. Acetaminophen or Tylenol will help, but what will help the most is non-steroidal anti-inflammatory drugs like ibuprofen, aspirin, naproxen, ketoprofen, or indomethacin. Why? Because they are anti-prostaglandins. I'm going to refer you to my presentation on aspirin, where I gave details of how aspirin works, particularly blocking cyclooxygenase 1 and cyclooxygenase 2. This time around, we need aspirin because that is going to block the prostaglandin, the same with all non-steroidal anti-inflammatory drugs. That is why in dysmenorrhea, where prostaglandin is the culprit, then the medications that could block prostaglandin, like non-steroidal anti-inflammatory drugs, are very effective. Celecoxib is cyclooxygenase 2 selective non-steroidal anti-inflammatory drugs. This one would be good if we want to avoid gastric ulceration, but then we are afraid of possible cardiac effects, which would not be encouraged because give myocardial infarction and retention of fluid. We are not going to give, in dysmenorrhea, we're not going to give opioids because all we need is to block the prostaglandin. Then hormonal contraception, combined oral contraceptives, just to prevent ovulation, and transcutaneous electrical nerve stimulation could be done, gonadotropin releasing hormone, endometrial ablation, and of course psychotherapy. I have put down psychotherapy here because when somebody is passing through this excruciating pain on a monthly basis, there is likelihood of being discouraged and becoming depressed. And every month, the individual is anxious about what will be coming. So psychotherapy will help, but will not cure anything, but at least it's going to prepare the mind psychologically. Acupuncture, diet and vitamins A, B6, D3, and ginger, tocolytics like nitroglycerin, nitric oxide, calcium channel blockers like difedipine, and magnesium. Why tocolytics? Okay, those who have had premature uterine contraction when they were pregnant would have heard about tocolytics being given to stop the contraction. And from this presentation, I've stated earlier that there will be non-rhythmic, repeated contraction of the uterus. So if you can give anything to stop that uterine contraction, you might be helping the woman. That is why tocolytics will be welcome here to prevent that non-rhythmic, continuous, or repeated contraction of the uterus. So tocolytics are helpful. I don't know much about the usefulness of phosphodiesterase inhibitor like Sildenafil officialis or Levitra, but some authorities will be comfortable with that. Buscopan, yes, I'm comfortable with that. And in secondary dysmenorrhea, particularly those who have had enough children and they are no longer expecting more child or children, then why not discuss with the husband and have hysterectomy done? Why? Once the uterus is gone, then dysmenorrhea is gone forever. What are the possible differential diagnoses here? It's possible this could be ectopic pregnancy, and I will refer you to my presentation on ectopic pregnancy, because here you need to find out if this woman had missed her period for a period of time. Most of the time it's going to be about 6 weeks or 2 months. Then signs of pregnancy, bleeding pattern, and you do your cervical excitation, tenderness, ultrasound. You see that the uterus is empty. There's no gestational sac in the uterus, and you check the adnesia, you're likely going to find it, and other ectopic sites. Details are in ectopic pregnancy presentation. Please check out. Could be urinary tract infection, could be fibroid, could be endometriosis, could be inflammatory bowel disease, gastroenteritis, adenomyosis, or endometritis. I'm back to ectopic pregnancy because that could kill very fast if that diagnosis is not made and appropriate intervention is not embarked upon. The woman can have what we call concealed bleeding and actually die. And it's very essential that we come down to that and rule that out before just placing the woman on NSAIDS or whatever. So thorough history, proper physical examination, appropriate investigations will save lives. Cause of the sapropinchatis, inflammation of the fallopian tube, mid-cycle ovulatory pain, has come into schemas. That's functional, and uterine perforation, particularly those who are using IUD. I'm not trying to scare you. I could refer you also to my presentation on intrauterine devices. Could be sexual abuse. Yes. Let me pause a bit here. When you see a teenager, a young woman with dysmenorrhea, find out about home environment. Assure her of confidentiality. Let her be free to express herself freely to you. Keep a secret secret. Get down to the root. This might be ongoing sexual abuse, because if that is not done, the young woman will go back to the same environment, to the same father or stepfather, or this woman is in a care home or is in a respite home or whatever. Please find out. It could even be the spouse, the husband. Find out, please. Depression, narcotic seeking. Yes, particularly those who want to take hydrocodone, hydromorphine, and so on and so forth. They are now presenting with fake pain. Try to find out. There are specific questions to find out whether this person is just seeking narcotics or not. This could be hernia, and this could be kidney stone. In conclusion, it is painful, but as a young lady, it's a teen of joy that you're menstruating. Why? There are so many women that have amenorrhea that is not secondary to pregnancy or any other cause like that, but primary, which means they've never had menses in their entire lifetime. That is painful to them because they don't have the hope of becoming a mother one day until they have seen an expert who will help them out. But if without the help of a doctor, you can become a woman on your own, that's a good thing. And the first sign of that, of you being able to be independently becoming a mother, is having menstrual flow that is associated with ovulation. So now you're having menstrual flow, you are having ovulation, but you're having pain. So it's painful, but as a young lady, it's a thing of joy that you are actually menstruating. Cooperate with your doctor and listen to your parents to help you out, particularly teenagers. We have them, they won't follow instructions, they just want the pain to get out as quickly as possible. Well, your parents love you, they want that done, your daughter is concerned, he or she will be happy to get that out, but you need to cooperate with them. I hope that employers and teachers will understand that that young lady may not be pretending. She may be passing through a very serious type of dysmenorrhea, and that is why she has called in sick at work, or she's at work today saying, I can't cope anymore, I can't cope with this pain, I just have to go home. Please understand with them. Or they are absenting themselves from school not because they don't want to do regular class works, but because they can't just cope with that horrible pain. I hope everybody understand them. So with this, I come to the conclusion on dysmenorrhea, wishing all affected young women well as they cope with this painful situation. Thank you for listening to my presentation. Kindly subscribe so that you can get these publications immediately they are released. Thanks.